Okay, good evening. I'm Leonard. I'm the Director of Medical Affairs at the Taiwan Adventist Hospital. And today I'm going to share with everybody about coping with COVID-19 in Taiwan from a hospital, from this perspective of a hospital in the Taiwan Adventist Hospital. First of all, a brief introduction to our hospital. The Taiwan Adventist Hospital, it was established in 1955 under the Adventist faith, under God's guidance. We are part of the Adventist healthcare system, which Dr. Landis has talked to us about before, which is a very large healthcare system under the Adventist faith that has hospitals all around the world, including the Loma Linda University and Medical Center and the White Memorial Medical Center, and lots of hospitals in Asia and all around the world. Our hospital now has total bed number of 389. It has a total number of staff around 1,000 with 100 or so physicians, 139 medical staff, around 500 nursing, and 300 other staff. Since healthcare in Taiwan is different from America, so sort of a comparison, we'll take the Zuckerberg San Francisco General Hospital that has around 403 acute beds, which is a level 1 trauma center in San Francisco that has a total staff of around 4,000 employees and is in charge of about 20% of all inpatient care in San Francisco. With our 1,000 staff and their 4,000 staff, our numbers are actually quite comparable. For ambulatory specialist clinic visits, each month we have around 38,000. For the San Francisco General Hospital, they have around 17,000. We perform about 800 surgeries a month. The San Francisco General Hospital performs around 600 a month. In-hospital patient days per month, the Taiwan Adventist Hospital has around 4,800. San Fran Gen has around 6,200. For length of stay, per stay, Taiwan Adventist Hospital has around 4.1, and for San Francisco General Hospital, it's about 5.2. ER visits, we have quite less, which is around 1,600 per month. San Francisco General Hospital has around 5,800 per month. There are about 100 babies born per month in the Taiwan Adventist Hospital, around 95 per month in San Francisco General. So for that, it's just a brief comparison between our hospital and another hospital in the United States to understand the volume and size of our hospital. Our hospital is a mid-sized regional hospital in the center of Taipei, which is the capital of Taiwan. We are under a single-payer universal healthcare in Taiwan, which is run by the government. We are well known for taking care of international patients. During the pandemic, we thought, we were pondering what is the responsibility of a hospital during the pandemic. So in general, we thought 3 important points. We want to protect our staff. We are responsible for screening and treating COVID patients, and also caring and protecting non-COVID patients. So we wanted to continue to provide healthcare for non-COVID patients, even during the pandemic. As a hospital, we found that our goals was to have absolutely no in-hospital COVID outbreaks, and hopefully to not miss any COVID patients. So all the COVID patients that visited our hospital, we hope that we would successfully test them and treat them and not have them go back into the community to cause community transmission. And also, we wanted to continue to provide healthcare to non-COVID patients. For our mentality against fighting COVID, that started about 17 years ago, since the SARS epidemic in 2003. Taiwan was hit very hard by the 2003 SARS epidemic. In this picture, this is an actual picture of 2003 of a hospital that had a very severe in-hospital outbreak and in-hospital transmission. So the hospital itself was locked down, and the patients and the hospital staff were all locked down within the hospital, which was a tragic story. After that, we always knew that we were on our own. We could not count on the help of the WHO or the international community due to our very special political status. So we knew that having quick reactions, having fairness in all our decisions, trusting the government was what we needed to do. And as a hospital, we did not want to become the weak link. We did not want to become the hospital that had in-hospital transmissions. So we did not want to become the weak link. This is also the mentality of Taiwan. Inside the international community, Taiwan also did not want to become the weak link that caused or is causing transmission all around the world. So that's what we were thinking entering the fight against COVID. For our responses as a hospital, we had organizational responses. We performed space allocation. We had personnel responses, communication, innovations, and also, very luckily, we had donations from the private sector. For our organizational responses, the Taiwan Adventist Hospital immediately had a Taiwan Adventist Hospital Wuhan pneumonia response team, which more politically corrected is called COVID-19, was established in early January. It was led by our hospital president, Dr. Huang, and the vice president of medical quality and infectious control, Dr. Yang, who was the speaker earlier. And it included members of the top management. We had and are having weekly socially distanced meetings, and also with a real-time chat group. First of all, for space allocation, the most important thing was having patient flow diversion. The main goal was creating a COVID treating hospital within a non-COVID hospital. So we had patient diversion starting from the front door. Temperatures were taken for all people entering the hospital. So using an infrared sensor, sort of a high-tech technology that probably everybody has seen right now, all patients, all people that were entering the hospital had their temperatures taken. People with fever were diverted to another floor, and people without fever or without travel, occupation, contact, or cluster history were diverted to a different pathway. So TOCC history, which is travel, occupation, cluster, and contact history, was taken for all people that entered the hospital. And for this, we had to thank the government, because the government used digital technology to have entry of border control history. So that's entry within or leaving the country, that kind of history connected to our healthcare database. So our staff could check if this patient has recently left the country or has recently entered the country using our national insurance card, which I'll talk about later. And patients with fever, COVID-related symptoms, and positive TOCC were diverged. So we very quickly rented some tents that were placed outside our hospital. And patients with fever, COVID-related symptoms, suspected patients, were then first sent to the tents to have testing before they could enter the hospital, thus successfully diverging the patients from non-COVID patients. And the tests were done in specific areas which were the tents, and also a special case space in the emergency department that was allocated for COVID-19 patients. Confirmed and suspected patients were sent to a designated COVID floor. Before the outbreak, we only had we only had 3 negative pressure isolation rooms. Within 3 days, we had a whole floor readjusted to be negative pressure. So as I said, more or less, we were preparing for this pandemic for 17 years. So our internal medicine ward has always had the capacity to be quickly adjusted to be a negative pressure isolation floor. So by adjusting the air conditioning system and also with some simple implements, we were able to readjust the whole floor to be negative pressure. It was a quick and dirty solution. So as we all know now that response time is very important, we chose to have good enough solutions to be good enough. So it wasn't a very pretty or a very refined way of changing it to be negative pressure, but it worked, and having something to work is good enough. And then we had our non-COVID internal medicine patients to be reallocated to the pediatrics ward. So during phase 1, the green area was non-COVID patients, and then the reddish area was the negative pressure area. So as I said, having a patient flow diversion was very important. So non-COVID wards were on one side of the floor and negative pressure area was on the other side. But very quickly, due to increase of suspected and confirmed cases, we shifted to phase 2, which the whole floor became a COVID treating ward, having both sides being negative pressure areas. And having clear divides was very important. So as you can see, the very large man-sized sign says that this is a restricted area. And with a sign that large, it reduced the chance of anybody coming into this area by accident. And for personnel, we had total involvement of all staff. So all hands on deck response is very important during this kind of crisis. We had closure of our hospital gym and cafeteria to reduce chance of transmission within the hospital. And a lot of personnel's jobs and jobs descriptions were changed during this pandemic. So we had transparency of tasks and the expectations that we had for the different personnel members. And for the nursing and doctors, all medical care staff and support staff, we tried to avoid having them crossing the COVID barrier. So if a nurse was caring for COVID patients, we tried to have it so that they were caring only for COVID patients and not treating non-COVID patients to reduce chance of in-hospital transmission of COVID-19. And with our experience with SARS from 2003, we found that supportive staff, such as the janitorial staff and other supportive staff, they often were the cause of in-hospital transmission. So in order to protect them, their personal health and safety, and also to protect our hospital, we had extra education for them, help them to learn how to properly use PPE, how to properly protect themselves. That way, by protecting them, we also protected our hospital and the community. This is, as I said, an all hands on deck pandemic. So it's not a problem only for the internal medicine staff. We had all full-time doctors under 55 years old assigned to rotate on night shifts for the COVID ward. And one of the main reasons that we were able to do this is after SARS, we had a nationwide general healthcare training for all specialists. So personally, I am a specialist in urology, but because I have received a general healthcare training, that means that I most likely am able to treat or care for COVID-19 patients in the most basic kind of manner. So I am qualified to treat for them. That way, maybe an ENT doctor or maybe an eye doctor wouldn't be able to say that because I'm an eye specialist, I won't be able to treat COVID-19 patients. So all our doctors, because of national policy, are trained to care for general health care. But we also supported our doctors. So we wrote survival guides for our COVID-19 duty doctors. So maybe a psychiatric specialty doctor, he could read the survival guide and know what to do or know who to call for help in a case that maybe has become more severe. For personnel change, we first of all had thorough implementation of staff health status report system. So if a member of our staff had a fever or had COVID-19 related symptoms, it was very important for them to report it through our health status report system. That way, they would receive testing and self-isolation. So in our hospital, all hospital staff were tested if they had any related symptoms. And they only returned to work after they had negative test results and improvement of their symptoms. For communication, which is very important. First of all, right in the beginning of the pandemic, there were a lot of different kinds of messages. The information was not that clear. Then, communication between other hospitals, learning from our peers. We had a lot of chat groups online that were talking about what things they were doing, what we were doing, what things they were experiencing. And we learned from them and we tried to share our experience. Within our staff, so very clear communication with our staff helped us to find out the needs and the places that were vulnerable, so we could shift our attention to the most vulnerable places. And also with our patients, and most importantly, between our government. So these pictures on the side is something that I thought is very important. That's why it's in the slides. This is after we had a patient from our COVID ward that worsened in their condition, in his condition. So he had to be transferred to the intensive care unit. During the transfer, we already had a SOP set up for the transfer. But during the transfer, we found that there were still many places that were not done as good as it could be. So then we had another mock transfer. And during this transfer, we noted that communication between all our teams, the nursing staff, the medical staff, was very important. And with patients and family, we had very clear communication with them. We had to have very clear information for them, such as we had them to know that without a TLCC, a travel occupation contacting cluster check, they could not enter our hospital. And as I was saying before, the three cards on the side, that's our national insurance health card, residency card, or ID card, a picture ID card. With these ID cards, we were able to check our national database to see if this patient has entered the country recently, has any travel history abroad. This was a database that was set up quickly in late June by our government. And with this TOCC check, we were able to diverge the patients that had positive travel history. And masks were and still are mandatory in our hospital. So right now, only because of the conference that we are not wearing masks, or else every day we wear masks, which is very important. I don't understand why people don't wear them, but there are masks in the hospital which are mandatory. Without a mask, you are not able to enter our hospital, and all hospitals likewise in our country. And to reduce contact, only a single accompanying family member is allowed. No visitors are allowed in our hospital. And a surgical mask is provided daily to each in-hospital patient, and another one also to their accompanying family member, which is provided by our government. For communication with the government, we found that trusting is very important. So trust, trust, trust. There has to be trust for us to go forward in the fight against the COVID-19 pandemic. And also information transparency, which I believe that our government has done quite well. So we know what's happening, we know what's going on, we know what's being planned to be done. And something that I read on the New York Post has resounded with me very deeply. So I'll read this for everyone. So they said that this is a opinion piece that was published on April 25th of 2020. It's Taiwan makes sure that its health institutions are hyper-vigilant about epidemic risks. After the SARS epidemic of 2003, if a threat is detected, containment plans and supply stockpiles are ready. The process starts at the bottom, not at the top. I completely agree with this opinion. So during January, when everything was starting, before there were any official regulations, we started implementing all the things that I was talking about, having the tents rented, having patient flow diversion, having personnel reallocation. This was all done before any official or government regulations. Because as a hospital, we were hyper-vigilant about the risks of such an epidemic. So we were doing all the things before there were any official regulations about how we should do it, or what, or if not, we're doing it. And during when we were making these changes, we were doing what was right and trusting that the authorities would support us afterwards. So this is what we call bottom-up decision making. It's not us as hospitals waiting for the governments to tell us that, oh, there is an epidemic or there is a pandemic, but instead, we being very careful and alert. And when we sense that there might be an epidemic or a pandemic, doing changes from the bottom, not waiting for an order from the government. And for innovations, because we know that patients who are elderly, patients who have pre-existing conditions are more at risk during this pandemic. We had outdoor prescription refills. So patients who had long-term medications for diabetes, for hypertension, they would not need to come into our hospital to refill their prescriptions. So the counter that you see actually is a doorway to our parking lot. But we changed it for it to become a counter for them to pick up their long-term medication. Instead of coming to the hospital, they only needed to come to the outside of the hospital where they could pick up our medication. And as I said, during a pandemic such as this, good enough solutions are good enough. So this is not a very pretty solution, but something that works is more important instead of how it looks like. We are right in the center of Taipei City, which is very space confined. Having social distancing because of this is actually quite hard. So we had a lot of innovations. So such as this is a rest and eating space for our operation room. And when we're eating, we're not able to be putting on surgical masks. So instead, we had these innovations to help them be social distancing. distance even when eating. And we canceled all non-essential meetings or changed them to online conferences. For our whole COVID floor, we had video surveillance installment in all the isolation rooms. As I said, within 3 days, we shifted a whole floor to become a COVID treating floor. And since they're isolation rooms, we're also afraid that there might be dangers to the patients that we're not seeing. So then we had video surveillance installment in all this. And it's lucky because Taiwan is what we call a very technical island. So very easily we were able to buy these webcams and install them hours. PPE is now an issue that everybody is talking about. So that includes protective face shields, goggles, hairnets, gloves, protective gowns, surgical masks, N95 respirators, full body protective suits. So right at the start of the pandemic, surgical masks, N95 respirators, full body protective suits were regulated by the government. They told us that they had a stockpile that was sufficient for the pandemic, and we should use them as we feel needed. And when we did not have enough, we could ask the government for more. Now, at the beginning of the pandemic, that was the information we got. And as I said, trust is very important. So we trusted our government and we used very conservatively, but we used the mask and respirators as needed. And as they promised, they replenished our stockpile as needed. So according to law here in Taiwan, the hospital has to have a 15-day or more stockpile ready. And after the outbreak, we had very careful management of our stockpile. And we all know that there is an ongoing struggle between safety and conservation. So we still had to use these PPEs, but we all still have to save them because there is always that chance of maybe something's being out of stock. And thankfully, we had very clear guidelines from our CDC, the Taiwanese CDC, for uses of the PPE for different situations. In our hospital, we had acrylic shields of all types made. So that is to maybe help reduce the use of PPE. But we noted that unless there was a real shortage of proper PPEs, the scientifically unproven acrylic shields will only be used for added protection. Unless in a very critical case of shortage, we will not have our staff be using the scientifically unproven acrylic shields for protection. Instead, we use the proper PPEs and then use the shields for added protection. For testing, that is something that everybody is also talking about. Here in Taiwan, testing is centrally regulated. It's done by RT-PCR, real-time PCR. So it's not antibody testing, it's RT-PCR testing. It's not done in our hospital. Results come back usually within hours and always less than 1 day. So who is tested? Who can be tested? Who will be tested? Testing capacity in Taiwan has been increasing daily during the pandemic. So starting from the beginning in January, only patients with related TOCC history were tested. And then it was expanded to highly suspected cases with or without related TOCC. And then to any patient, right? So right now, any patient that is clinically suspected to be with pneumonia or clinically suspected to have a COVID-19 infection. But to conserve the capacity of testing, the public cannot ask for a test without a sufficient reason. That way, because we all know that everybody is worried about COVID-19, so it is regulated that only if a patient is suspected by a doctor or a healthcare official, a healthcare specialist, that they are at risk of COVID-19, or that if they have been in contact with a case of COVID-19, that they can have testing. We were very lucky and we are very thankful to have donations from the private sector. MediaTek, which is a major Taiwanese semiconductor company, donated 2 UV disinfectors to a hospital, which cost more than 60K American dollars. And also many businesses and people have prepared meals for our staff to express their support to the frontline healthcare specialists. That is something that is very heartwarming, because being on the front line, that has been very hard and also with a lot of stress. But when we receive the meals and the gifts from our community, we feel that we are more able to fight this pandemic. Of course, like in all fights, not everything is great. We faced a lot of difficulties, so reasonable and fair allocation of PPE to different units is something that has been an issue in our hospital. Also, having non-internal medicine docs and nurse practitioners help share the load. So we had to have very clear communication. So as I just said, different doctors, all doctors in the hospital, also have to help fight COVID-19, which is something that required a lot of communication between them for them to understand what we wanted them to do and what was their responsibility. And as I said, as being a relatively small in size hospital in Taipei, we had a challenge to diverge our COVID and non-COVID patient flow in our hospital. So when we had transfers from our COVID ward to our negative pressure ward, or transfers to other hospitals, that is something that was quite challenging. So before the transfer, we had meetings to understand how we should move the patient without risking our staff or our other patients. And the picture on the right upper side is a picture that talks about teamwork. So we can see nurses, we can see even our security staff, our cleaning staff, our RT specialist, a doctor, and also our MPs. A whole team of different specialties have to have a conference before we had that transfer. So that talks about teamwork during this pandemic. So in conclusion, we had total staff involvement. We had transparency with good communication. Bottom-up decision-making, which is our staff at the front line telling us the needs, the risks, not them waiting for our decision at management level. And also, as I said, simple and good enough solutions on time are much better than very pretty solutions that are late. So simple and good enough solutions on time. Reopening now is a major issue all around the world. So Taiwan is very lucky to have, counting today, 52 days without local coronavirus cases. So in total, we had 443 positive cases and 7 deaths, and 52 days without any new local transmissions. Due to this, we are reopening. But before we reopen, we have to assess the condition. So to clarify, here in Taiwan, there were community-acquired cases. There were local cases whose infection origin could not be found. So even with very extensive contact tracing, there were cases who we were not able to find where they got the virus from. And in one certain hospital in Taiwan, there was cases of in-hospital outbreak. But here in Taiwan, there weren't lockdowns. There were not stay-at-home orders. There were social distancing guidelines, but there were no stay-at-home orders, and there were no closings of businesses or schools, so the economy was not closed. In our hospital, we started to relax the measures. So the tents were removed. The COVID ward that I said was changed to a whole floor was then downsized to phase 1, which was half a floor. Our gym in our cafeteria was first open to our staff and then to the public. And then our TOCC checkpoint right at the front door was removed and then replaced to be only a body temperature checkpoint. So going back to normal, we are keeping vigilant with all patients. We are staying alert about the chance of an outbreak in Taiwan. So Taiwan is very lucky to not have a very severe outbreak right now, but there's always that chance. So as a hospital, we're staying alert and watching out. And if there are any signs or signals that there might be that chance, we are always ready to jump back into action. We are able to re-implement all of the changes that I talked about today. And we will not be waiting for a government issue to tell us, or government order to tell us what to do. If we sense that there might be that chance, we'll be re-implementing everything I'm talking about. So everybody is asking if we're able to return back to normal after this pandemic. So from the Taiwan experience, being vigilant, being ready to fight a pandemic, being ready to have action before there are orders, that is the normal after the pandemic. So the fight is far from over, but through cooperation, I feel that we can have better results. Thank you.
Thank you, Dr. Che.